with patients who have terminal illnesses. Now, research tells us that doctors and surgeons in particular hate to deal with terminal patients because they remind them of their helplessness. And surgeons, like true craftsmen and women, do not like to sit around doing nothing in the face of a problem. It is considered one of the leading reasons why many surgeons would shy away from oncology. That's what research tells us. This is compounded by the pleas of caregivers to intervene where surgical options no longer exist. So what happens is one of three things: unnecessary surgical interventions, send the patients to do more chemo, or tell the patient there's nothing to do and send them back to their local doctors. The first option is clearly wrong, and there is no need for argument here. I want to address the other two. Again, there's a big translation job that must be done here. Why do chemo patients cells when we are constantly told there is no evidence that it does any good? Isn't this why we had site reduction and hypo to begin with and not systemic chemo? You tell us it doesn't work. Now I'm dying and you're sending me back to chemo. That doesn't make any sense. And we have no good answers for that. As to those sent to the local doctors, there are no clear palliative measures that will stop obstructions and terminal starvation. People need to know that before they're sent to hospice or to their local doctors, because they expect too much, and they keep calling your offices constantly, and there's nothing you can do, there's nothing the family can do, and it all boils down to the communication of what are the actual realistic options available out there. And I tried to dig up the research just to understand what happens at the later stages of pseudomyxoma peritonei, and nobody writes about that. We read obstructions and terminal starvation. Nobody wants to describe the dying process because that's not your job. And I do understand you're trying to stay away from that because you want to fix the problem. But also, I think what is affecting the fixing of the problem is ignoring the times that we can't fix the problem. And here is a huge effort that needs to be done there. Also, I think the cooperation of patient support groups to really describe that process and describe the valuable options that exist out there. It is important. Okay, so what is that? We close off the balcony door. Number one, educating general surgeons, GPs, and medical oncologists about PSNs, site reductive surgery, and IPAC. And this is something that we can help with. This is something that patients are really good at. We harass them. And we harass them very well, and we can reach general surgeons everywhere. But this has to be done under the supervision of the people who can approve that material. Number two, putting more effort into informed consent, guaranteeing language, that the language is understandable by the patient, and your expectations and the patient's expectations are one and the same. A lot of times people go into site reductive surgery and then they come complaining that I drove all this way. Dr. Schneebecker was giving me an example this morning that people complain that they didn't get HIPAC. And I think there's a lot that has to be done prior to surgery to prepare people for the options, the adverse options that they might end up with. Also the adverse events that the surgery might lead to. And I don't think that patients understand this very well. Number three, reaching better consensus amongst yourselves about the pathology, the grading of the diseases, patient selection, the extent of site reduction, systemic chemo, diagnostics. These are the things that we expect you to reach consensus. And we were very happy with the Milano meeting because it seemed that a lot of people were in agreement. But we come to papers for conferences like this one, and then we feel, oh boy, they're disagreeing again, and we don't really know what the evidence is. And I know that one follows their common sense because that's what you do. Craftsmen, craftswomen should follow their common sense. And the common sense says wherever is the majority of the evidence is where you go, and you don't go against that. But I cannot say this to patients. Physicians, specialists need to say this to patients. So consensus is incredibly important. Dr. Moran this morning was speaking about the possibility of some international entity that will sort of possibly draft guidelines that everybody can emulate and follow. That's very, very important. I understand that we can never have complete agreements because medicine, like any other science, is evolving all the time. But the level of disagreement amongst yourselves sometimes leads to lesser quality care or lesser compliance by patients. And that's, I think, is important. Number 4, creating a more effective system for patient support and follow-up, a place to go for questions and follow-up tests. And I think the UK also has a good example for patient support groups that are established by the centers and for call centers that patients can call in and get actual answers, not from administrative staff, but from people who are medically, who have a medical background and they can actually answer these questions. And I think that's an experience to emulate. Number 5, addressing terminal cases and the choices available for palliation and end-of-life expectations. And I think you should go against your aversion to addressing that stage, although it's understandable. Number 6, opening channels of collaboration with patient support groups who are both willing and equipped to assist in all these tasks. Mr. Jerry Lewandowski from PMP Research Foundation could speak to this more because I'm not really involved in any of the great efforts that they made, but they awarded $250,000 just to support research for PMP. And so these things exist, and the support that patients can provide to do more research and to develop and improve and optimize the treatment is a very realistic choice, and I think that should be addressed too. Number 7, to continue to do the marvelous job that you're doing. And that is something you need to understand. We know I, for one person, would not be here today if it weren't for the wonderful group of people you are, and if it weren't for the wonderful job that you do, and if it weren't for your dedication, your willingness. I don't know other group of doctors who are willing to sit in an operating room for 20 hours, but I hear you do that on a routine basis, and that's something that